Okay, as far as committee members go, I have Wanda, Julia, Patricia, Keisha, Roger. Did I miss anyone while they were signing in? Or is anyone logged in on a phone number? Okay, we'll need one more before we can establish a quorum. And I will scroll through to make sure I didn't miss anybody. So we'll give it just another minute longer. I don't see any more committee members at this time, but if you want to go ahead and start, if anyone else joins, I will stop and let you know.
Great, thanks. Thanks everyone for joining this afternoon. And is Leslie on? I didn't see.
I am. I'm
Oh,
on.
great. Would you like to say a few comments of welcome before I get started?
Yes, and then yes, that'd be fine. So welcome and good afternoon to everybody. My name is Leslie Hoffman. I'm the Deputy Commissioner for the Department of Medicaid Services, and I proudly serve as one of Medicaid's Racial and Health Equity Champions. This is our third official Health Disparity and Equity TAC. Very exciting. And DMS is very excited about partnering with this TAC in 2023. So I have updates later, Dr. Richardson, and we can share those later.
Great. Thank you, Leslie. I thought as part of my welcome, since, you know, it's so hard, we're not in person, it's hard to get to know each other, I wanted to do just a quick icebreaker for the TAC committee members. And so we'll just do something silly like your favorite holiday dessert. Just say your name, your day job or your advocacy work, whatever you want to say, and then just your favorite holiday dessert. And I see Roger, would you like to share?
My favorite holiday dessert, probably sweet potato pie. As you all know, I'm a professor in the College of Education at East Kentucky University.
Thanks. Patricia, I see you. What about you?
Hello, everybody. I'm Patricia Bautista Cervera, La Casita Center Health Empowerment Coordinator. My favorite dessert, apple pie with ice cream.
And I can't tell, it's hard for me to tell on my screen who else is here. I don't know, Erin, can you tell me who's here?
Wanda, how about you? You want to go next? She was logged in. Did we lose her? How about Keisha?
That's me.
Oh, there you go.
I needed to mute myself. I'm sorry. I'm Wanda Figueroa. I'm the CEO of River Valley Behavioral Health, and my favorite dessert is a Puerto Rican flan, which is a custard very similar to creme brulee.
Thank you. And then Keisha.
Hi, my name is Keisha Curry, and I am a social worker with Signature Healthcare Services out of Louisville. And my favorite dessert is lemon cake with a scoop of vanilla ice cream.
Great.
Jordan just joined.
Sorry, I was having trouble finding the link.
Oh, so Jordan, we're just doing quick introductions and then your favorite holiday dessert.
Say that again, sorry.
Oh, just quick introduction for yourself and your favorite holiday dessert.
Got it.
So you're next, you're up.
Got it. favorite holiday dessert is just a quick introduction to Jordan
Sure, yeah.
Burke, pediatrician in Eastern Kentucky at Primary Care Centers. Favorite holiday dessert, probably like dirt cake. You know, it's got like that Oreo, like and like stuff like that. It's probably my go-to. Can only eat so much of it, but it's solid.
Great. Has anybody else jumped on, Erin?
No, ma'am, but you do
Okay.
have a quorum now. If all of your committee members can turn their cameras on, you can establish a quorum and approve your minutes from last meeting.
Before I want to do a little bit more on the welcome before we jump in to that. So I'm Julia Richardson, pediatrician, Family Health Centers, Community Health Center here in Louisville. And this, it's always about the cookies for me. But this year, my daughter and I made gingerbread cookies, which we'd never made before. So those were good. So that's my new favorite. I wanted to, just as part of my welcome, you know, we're taking turns on being chairperson. I'm taking my turn. So I just wanted to give you a little background for the members and for DMS. So first, when I was thinking about just as part of a welcome to this meeting, when I was kind of thinking about the agenda, the way I laid it out was kind of the first half is DMS kind of talking to us, updates, things like that. And then the last half will be us more driving the conversation about what our priorities are. I think it's both important for DMS to kind of give us those windows of how to contribute, what's going to be meaningful for you. We want to give you information that you can use because we've got plenty of feedback, but we want to kind of frame it in a way that you can use it most effectively. And so giving us sort of this first half of the meeting, telling us what's going on with your work. And as you're talking, kind of try to pull that out when you're giving us your updates. Like if you can think of any questions for us to give really specific feedback, and anything that would be really helpful to facilitate the conversation. And then the same thing when we're doing some of the new business and general discussion, trying to help us both understand how we can help each other, because clearly we're all on the same page. We want to do the same work, but how do we sort of, most effectively communicate in a way that it's actionable for Medicaid's work. So I wanted to kind of say that up front. The other thing I wanted to say, the process for that I did for this meeting, and I think I'd share one more, and then I'll, unless somebody wants to chair next time, I'll chair one more and then we'll rotate. The minutes are amazing. I love having the full transcript. It's great. Makes it easier to go back and remember what everyone said. So hopefully we get that again, right? Do we get the full transcript again for next time?
Yes, ma'am. We have a court reporter who logs in, and we also send her or him, depending on who's on, the full recording. And they do a full transcript from that.
Great. So basically, to prep this agenda, I just went through the prior transcript and pulled out all of the things we said we were going to follow up on, or we want to talk about the next meeting. So that's how we created the agenda for this time. It's basically based off of the last meeting minutes. Going forward, I think it would be helpful after the minutes come out, maybe I'll meet with DMS so that we can run through the minutes and pull out what you all really want to report on, pull out what sort of from the minutes came up as priorities, and make sure that, that would be appropriate for the next meeting. But also at the end of this meeting and throughout the meeting, throw out ideas if you want to talk about them next time, so we capture all that for the next meeting agenda. Ideally, with the holidays, if time ran short, so I wasn't able to really get the agenda out to the group to give feedback on specifically. So the goal will be about a month before the next meeting, we'll get the agenda out to everybody with feedback so we can formalize the agenda at least 2 weeks prior.
Dr. Richardson, if I could just hop in really quickly, as long as, so Medicaid is here to assist, but this is your all's meeting. We're happy to have emails back and forth with you on the agenda and items you'd like to discuss.
Yes.
The best plan of action is for you to email the TAC as a whole.
Yes.
To discuss the agenda items that they would like to see.
Yeah,
So
I'm going to do
that
it
way-
like a month before.
Yes, ma'am, but that
just
way
make
it
it,
ensures if you do that in an email forum, it would keep us within the law and the guidance of our open records policy and open meetings. So I would suggest, and I can send you a list of all the TAC members and their email addresses.
It would
And then
be
just
most-
CC us and we can make sure that we can jump in and help as needed. But DMS typically outside of the first couple meetings, we don't gear the agenda to what we want. It's what you guys would like to see.
Right, but I think it will help me know what we want if I can have that conversation with DMS after we get the minutes back. Because there might be 20 things we say we want to follow up on, and I want to have that conversation with you all. It's easier for me to set the agenda if we can have that conversation. And then, like I said, a month before, then we'll send it out for, to the whole TAC with plenty of time for feedback. Obviously, anybody can email suggestions for the agenda, and we always have the open discussion, general discussion time. In my experience, setting up this agenda, there were a lot of things that would have been, that I'm like, oh, I wonder if DMS has time for this. Is the staff even going to be available at the next meeting? Those are the types of things I'd like to get clarified before we send the agenda out with DMS. Great. And then I know I had hoped to have attachments sent out. I think just the agenda went out. The attachments didn't go out. So I'm wondering, is there a place on the website for this TAC that we can hold documents, or is that
You
not
didn't
possible?
send me any attachments. If you send those to me before the meeting, I'm always happy to screen share if needed.
So those were just the things that had gone out before. So I didn't send them back to you because they were things that had already been sent to us. They were just those, the last meeting minutes, the minority status health report, and the quality strategy for Medicaid. Those were things that were discussed at the last meeting that we wanted to send out. So I don't have them. We were hoping to get those sent out. But is there a place on the internet, on
The
our
website,
the
your
TAC
webpage, anything that's presented in the meetings and shared are uploaded to the website, and anything that are shared in your meetings, I try to send out to you within a couple days of the last meeting so that you have that.
Perfect.
If that's something you want me to reshare during the next meeting, you just have to let me know so I can have it pulled up and ready to be shared.
Perfect. Yeah. So I'll just put on the agenda attached documents, and that way you'll know which documents to send out. And then if we could get these 3 documents put up on that TAC website, maybe put the link in the chat so everybody knows where that is. That would be great. So for kind of governance, I think those are the only things I wanted to go over. Oh, the only other thing was some TACs do have bylaws. If anybody would like to establish bylaws, that's fine. I don't feel strongly about them right now personally, but we can talk about that. In prior administrations, the prior administration, they told us that TAC bylaws didn't stand. And so we weren't able to use them. So I didn't know because they said that we can only go by what's in the actual KRS. So I don't know. This administration may have different feelings about the bylaws, but I don't know. I don't know how DMS feels. Leslie, do you have any opinion on the bylaws?
I'm not sure about the bylaws. We do abide by the KRS. Aaron, do you know if each TAC established their own individual bylaws?
No, they go by the MAC bylaws, which were shared when the committee was first put together. I can resend those out for review.
And
I
so
know this TAC
yeah.
meeting is slightly different. It's not required to report to the MAC, but I believe it was stated that they would like to report to the MAC to bring some of the issues they find moving forward.
Great. So we won't worry with any bylaws. Okay. Unless somebody wants to, they can bring that up. Okay. So so just to regroup. So the way I set the agenda, the first half of the agenda is working with mostly DMS reporting so that we can understand where to plug in our feedback and our comments. And then the second half is some new business and general discussion. So more of an open discussion about our perspective on equity and hopefully provide information that's helpful for Medicaid. So we will establish the quorum. So I think quorum is established. The next thing is approving the minutes from the previous meeting that were emailed out. And so is there a motion to approve the meeting of November the 2nd.
So move.
Great. Is there a second?
I second it.
Thanks. Any other further discussion or changes to the minutes? Hearing none, all those in favor of approving the minutes say aye.
Aye.
Great. Any opposed? All right, so we have approved our prior minutes. So if you look at the agenda, the old minutes, again, pulled from the prior discussion that we had at the last meeting. So I thought it'd be helpful to review the health equity infographic and get updates from that. The MIC, if there are any updates from that project we talked about last time, the GARE tool, and then have some time with Vivian to talk about our goals and strategies and review those. So who's going to do the health equity infographic?
I will. Yes,
Sorry.
this is Jody Allen. Yes, I'm a behavioral health specialist with the Department for Medicaid Services. I am going to give an update on the infographic, and actually going over the infographic is going to cover 1, 2, and 3. So I'll give you a little bit of an update. Just as far as a backstory, just as a reminder, I'm really proud and excited to be a champion for the racial equity core team for DMS. And all of this came from the cabinet level initiative to create a racial equity action plan. So DMS has created one of those, and we are working on implementing and going forward, making lots of great progress. We had a meeting this morning with the community of practice cabinet wide, and it's really exciting to hear all the things, the initiatives that are pushing forward through this racial equity action plan. So that's a little bit of the backstory and kind of what's guiding all of this. Let me share my screen. Can you all see that? Okay, great. So this is just kind of an infographic that gives you a quick snip picture of all the things that we're doing within DMS towards the enhancement of racial and health equity. So it goes over our vision, the pillars, the cabinet vision, and we kind of covered that last time. Our overarching equity goals, and I will tell you that across the board, all divisions within DMS are working towards each of these goals. So integrating equity in policies, creating a diverse and inclusive workforce, hiring equity-focused vendors, fostering understanding of racial and health equity. So all of these things are happening through our racial equity action plan across the board. So those are our overarching goals. Some of our progress that I wanted to update you on, all DMS divisions have been trained in the GARE tool, which is the Government Alliance on Racial Equity tool, which is an accountability tool for racial and health equity. All of us have been trained, and all of us have submitted our first GARE tool implementation. And so we met that goal that was set for the end of the year. And so we met that goal, which is really exciting. And so now we're in the process of regrouping as a core team and discussing our next steps and what's to come as we continue to use that accountability tool with all of our initiatives across the board. Another thing, obviously, we created new programs to expand postpartum coverage. That's ongoing. Integrated care, enhancing mobile crisis, which we have finished the mobile crisis planning grant. And now we are moving towards the implementation phase of the mobile crisis, which is going to include meeting needs of all Kentuckians, regardless of ability to pay, regardless of severity level and need, and just meeting people where they are in their needs. Expanding services for the severely mentally ill, and we're doing that through the 1115 SMI waiver. We actually submitted our rough draft to CMS at the end of the year to enhance services for individuals with SMI, and we're also in the process of applying for additional waiver authorities, and so to expand services. So those things are ongoing. We've also created an equity determinants of health branch within DMS, and you're going to hear from them in just a little bit, and some of the updates from that area. So that's really exciting. A lot of this racial equity core team work is going to actually be moving to that area. So we expect them to really take more of a lead role in all of this as it goes forward. So full implementation of the GARE tool across the board. You'll hear a little bit about the CCBHC, which is also an integrated way that we are enhancing health equity in Kentucky. Let's talk a little bit about the Medicaid Innovative Collaborative. So the MIC, which is going to be a state cohort. We are participating in a state cohort that is focused on racial and health equity, specifically in the area of social determinants of health or social drivers of health. There's also other terms now that are being used for social determinants of health, but that's going to be the focus of the Medicaid Innovative Collaborative as it specifically relates to DMS in Kentucky. And so we've added a state. So it's Kentucky, Nevada, New York, and Iowa. And our kickoff is actually going to be this month. So we are meeting not only with our team, our core team that's going to be responsible for this Medicaid Innovative Collaborative cohort, but also all the states. So we're hoping to get that completely kicked off this month and up and running. So that's really exciting and is moving forward. And I believe that that is all of the updates as far as the Racial Equity Action Plan and the initiatives that are going on right now in DMS. Do y'all have any questions?
Can you, I know it's so much and it's, you know, so many moving parts, but can you think of even just saying, picking the MIC, for example, or the MIC, what role can we as the TAC members, what kind of information can we give you, kind of feedback that would be helpful, for example, in that, or any element, anything that you've talked about?
Julia, that's a great question. And I will tell you that as we're moving forward and as we do this kickoff, I know that there's going to be a need definitely for community partnership and involvement in that way. And that is definitely a very specific place that we're going to need your all's help, guidance, feedback, and even information.
Great. Yeah. So as that moves forward, you know, just any, you know, and as specific as possible so we can give effective feedback or contributions.
I appreciate that. Yeah, we'll definitely keep that in mind as we're just really in the beginning phases with that for sure.
And Dr. Cantor asked if the MCOs can be included in the collaborative.
Yes, and they will be. Yes, they will be. They will be included. There's already some pre-conversations and conversations moving forward with that and working with Angie Parker and that area as far as the MCO involvement and inclusion.
And then can you scroll back up to the top?
Sure.
Yeah, just so we can get, so we talked about the MIC. Oh, the GARE tool.
Yes.
So will we discuss the results of the what you all find using the GARE tool? Is that a way that we can we help there in any way?
Yes, I think that that would be a great place for us to have some discussion. I know that the next racial equity core team that's going to be a focus is on the GARE tools that were submitted, maybe reviewing those, taking a look at what more is needed and getting some feedback.
Might be a good idea, Jody, too, that we could show an example, like for our behavioral health team. You know, we had one particular focus, and so we could show you the one we did. Or if you want to see another divisions, we can get that. Or
just get some feedback.
I've mentioned before, if you want to hear from other departments in the cabinet, we could bring some of their information as well, or have them to speak in report outs.
I think that would be interesting. Is there a division that you think we would be able to provide the best communication with, or that we could be most helpful to?
Well, Jody and I have both worked on the behavioral health one, so we probably know that one the best. Everybody did a really good job in all their areas. So I was just thinking we might could present that one, since Jody and I are very familiar with that one.
Great.
And I think once we have a little bit more of review time with the core team, that would probably be a good place to see what, where do we need feedback or some guidance from you all.
Great. Thanks, Jody.
Sure.
Any
Dr.
other questions?
Sorry,
I'm sorry.
Dr. Richardson, I just wanted to mention that I met with Beth Fisher. I think she's on today, and one of her main focuses is going to be to promote in the communities on all of our social media platforms about the good work that we're doing. And the infographic will update that basically of all the things that Jody spoke about today.
Great. Okay, so lots of ideas for future discussions. Does anybody have any questions on the core team's work or the action plan or anything on the infographic? All right, so we will move on to spend some time with Vivian to pick up where we left off on our committee goals, strategies. Where should we go today, Vivian?
So, Dr. Richardson, I can give you information on the minority health status report.
Okay,
Put the link in the chat. It is up on our webpage. It is on the internet. It is being presented to LRC, Legislative Research Commission. So the 2021 is available, not just the executive summary, but the full report. We also have a supplemental that's coming out of additional data that we found that was very interesting and just too much to put in the minority health status report. It would have been too large. So additional data is there in the supplemental. It's still being reviewed. It hasn't been finished yet. It will be coming in the next week or two. We put up hopefully. And then we're currently starting to work on the 2023 minority health status report, which will be due in October for review. And then will be presented to the legislative committee in January of 2024. So we're already digging into new data to kind of refine and see where some of those gaps still are and where new gaps may be presenting themselves and where we're still kind of in a holding pattern with the work that we're doing in addressing disparities and social determinants of health. We're working with a data services vendor to try to have some community conversation as to where we are in providing services to our stakeholders and to our community. We'd be happy to have some input from this group as to what some of those questions are that we might be looking to have answers to. What do we want to know? What do we feel like we don't know enough about? So that would be helpful as we have our data support services vendors go out and have these external conversations. So looking forward to some input there from this group as to what you'd like to know from our constituents. As it relates to services, as it relates to programming, as it relates to our visibility, as it relates to all of those different things. So that's where we are with that. It kind of ties into the CHFS listen. So we're trying to have our own listening sessions within VPH, but we feel like there's a lot of crossover here with collaboration between these departments and the different racial equity core teams. And all the initiatives that are very similar there that are coming out to address some of the inequities across the state. I think it would be apropos for us to kind of work together on this and not have two separate things going out. Or maybe we can combine those in some way. Because I know how people are with surveys. I'm not wasting time, so I get too many. I'm like, well, what is this one about and how is it different from this one?
Yeah.
And if they're asking the same thing, I pick and choose sometimes which one that I respond to, so I don't want that to be an issue with this group. So that's my ask. You, Dr. Richardson, and this team, to kind of help formulate what some of those community conversations might look like.
great. Hey, Vivian, I can, you're cutting out a little bit. I don't know if it's just for me. I don't know if you can adjust your mic.
It's up all the way.
Oh, that's much better.
I have to lean into the mic. I gotta lean into the microphone for my laptop, so I apologize. And it's not. I need a new one. That's all I'm gonna say. I need a new one. But
Well,
can you hear me better now?
Yes, yeah, much
Okay.
better.
All right.
So-
So I have 3 screens. So I'm back to my main screen. Maybe that'll help too. All right. So did you hear most of what I said, Julia, or do I need to repeat it? Did everybody hear most of what I said? Jody?
Yes.
Okay. All right, great.
I'm wondering if we could pick one of those things that you mentioned or a couple of them and give you some feedback now. I think you had mentioned where I was making notes. Some things that I think you said, what are some of the things that we as a community want to know, or what
Right.
did you say? Can you rephrase that?
Yeah, so what we're trying to do is kind of have a conversation with our stakeholders and community partners as to, what are we doing well? What are we not doing well? What are some of the gaps they see as it relates to services, as it relates to programming, as it relates to just being visible? And what is it that we're missing with our staffing? And we talked about this morning in the community of practice core teams, the diversity of our staff and how we want to make sure that we're more inclusive in our hiring and the diversity of those that we hire to reach the populations that we serve. So we're very interested in hearing from the community and what they envision or what they see that would look like. So those are some of the areas, Julia, that we're really going to be focusing on. And if there's additional areas that this group would like us to focus on, or additional questions that Jody and her team might want us to put into this community conversation, as I call it, then that's what we need to know. And then I was just reiterating that, I don't want us to be duplicating efforts. I mean, if we can do this together, or if there's some things that we can, from this group, that we can combine in ours, we're more than happy to do that.
So I'm wondering if we could take a minute right now, if you wanted to lead us in a discussion about, so you said program services, eligibility, what's working, what's not working, because I'm sure we could all contribute to that conversation. Would that be okay if we jumped into that a little bit in a way that's helpful for you?
That's fine, right? And when we think of social determinants of health, are we really addressing those needs for the community? Are we forgetting about those? Are we doing an adequate job? Can we do a better job in incorporating the social determinants of health in the work that we do? Just, if that's where we're going to be doing midstream, upstream work, then we need to start talking and having that conversation around it. So.
Great. I don't know if anybody wants to jump in, or if we want to do a talking circle of some sort so we all contribute, or would anybody like to jump in and talk about something that's working or not working from your perspective as you work with people who have Medicaid?
Yeah, I mean, I don't know. Again, there's a lot of different departments and things. So I'm not sure exactly what does not fall under your area, but I know where I'm from, transport's like a huge one, right? So if I have a need for a patient to see a subspecialist, pediatric subspecialty care is 2 hours away, right? So it's not like a public transport thing. There is Medicaid transport that they can set up, but it's at least what most patients tell me, it's, they have to have days or weeks in advance in order to plan it. And so it's not the easiest thing to truly coordinate. And so if I do get them an appointment and, their car breaks down the day beforehand, they don't have the, means to get that fixed or to find an alternative way or to pay for a different ride. And so they end up missing and then, it's an appointment that's been 3 or 4 months out already. And then we have to reschedule it. And then, so, I mean, I hear that story, probably once every other week at least, if not every week. And so, I mean, at least from my perspective, transport's definitely a big one.
Yeah, we hear that a lot.
I'm not sure what the best way to fix that is, but I mean, that's definitely an area that I know we're out here that we definitely struggle with, especially for kids, because again, I don't have anywhere closer that I can send them to.
Mm-hmm.
So can I ask a question about telehealth as an option? Do you utilize that?
There are some places and locations like endocrinology has, I know at UK has some things that they'll do through telehealth. the issue is that like if I'm sending a kid to UK, it's typically for something that like they need to be evaluated in person, whether it's cardiology with a pediatric echo, or they need to see a neurologist, which I feel like that they really like their hands on exams, or if there are avenues and some subspecialists where telehealth works fairly well, and I think Pikeville has some things set up where they're able to do telehealth through over there, and so we can get them to there. And so there's options, but I mean, there's definitely room for improvement.
I was just looking at some new data that has come out that was showing that a majority of the folks, well, not quite the majority, but I think it was around 40% of the people during the pandemic were utilizing telehealth and thought it was very helpful and useful for them. And that if they didn't have that option, they wouldn't have been able to have that continued care through the pandemic. So just through that, I was just throwing that out there as a conversation.
Yeah.
I think that that's something that we should kind of continue to talk about in this group as being something that we might want to consider as a gap. And, when people can't have access, telehealth is an opportunity when they don't have direct access to transportation is an issue. So.
Yeah, for sure. And I mean, I think at least through, I guess with how it's set up at Pikeville, right? They have location where people will come and then they'll do telehealth from that location. Because I know for me, if a lot of my patients, if they were to have like a telehealth appointment, they still need the means of like internet, like an electronic device to actually connect, someone to help them figure the system out. If it's through an app or things like that, like, for the sake of like other people's schedules, to have it in a timely manner. That's, if there's outlying locations that can help coordinate that would probably be useful.
So transportation is a big one. Anyone else think of things they want to know about related to either Medicaid services or to staffing or to some of the other things related that we can incorporate as it relates to social determinants, as it relates to racial equity, as it relates to equity in general?
I would second what Dr. Jordan just mentioned, and I'm in the city, and I think Dr. Richardson would be the best witness to this missing appointments for not only for pediatric population, but for all the population. The lack of transportation within the Latinx community is one of the biggest problems. And if we add to this cultural misunderstanding and barriers of language or literacy, the problems get compound. But I think with the huge need for flu vaccines at this moment, with the severity of the transmission of influenza, I think transportation and the availability and the access to flu vaccines, it's going to be a big trouble for the population that I accompany with La Casita Center.
So Dr. Batista, just a question around communication. We talked about how that messaging is getting out, and we talked about the literacy level and language. Is there something we could do better as it relates to communication and things that we're getting out to these communities as far as messaging, or is that something that you think we've done a pretty good job on, or we need to improve that?
With La Casita Center, we produce our own videos and our own infographics, and we work with Family Health Center. We have been partnering with them not only for the medical assistance, but we share a community health worker that speaks Spanish. So it's serving both organizations and it's serving this specific community. So we are working as a team, and I'm the one that makes the videos and the infographics and puts the voice to them, because we need to pass on the information that we're receiving.
Mm-hmm.
And we use the CDC information and whatever we find into the Public Health Department of Kentucky.
Yeah, okay. But you're able to do it in-house. Is that the same situation for everyone else? To do things in-house? I know our state system is a little bit different with communications, but there's some other folks on the call too, on this call that may think we need to do a better job of communicating. Just a question. And you said something else about CHWs, which is are very fond, I'm very fond of and near and dear. So. Someone else was trying to say something that thought I heard someone trying to chime in. CHWs are becoming kind of that bridge now to connect communities to services and to programming. So, you know, our CHWs right now, we're thinking about sustainability funding for them through kind of a blended approach to Medicaid and another funding source. So, you know, do we see CHW being something that we want to ask community folks about, or do we think there's enough information we have already about their usefulness, their accessibility to communities, how we can better support them? I'm just throwing ideas out here, you guys. I'm trying to get some direction on where additional questions we can kind of ask our communities when we go out to talk with them. I think one of the questions is how are we listening, and how can we listen more effectively, and how can we be more effective in hearing what they want? Do they feel like that it hits a brick wall? Do they feel like it's getting through? Is there another way they should be communicating their issues or concerns? I mean, we're assuming a lot when we go out to talk to communities already. So,
Vivian, what are you all doing currently to get voice from the community?
Cleveland, I didn't hear you in the meeting a little bit.
I said, what are you all doing currently just to get input from the community folks right now?
I'll be honest, it's usually, Dr. Cleveland, convenience where we already have either grant funding or where we're already working in communities. We're not reaching out to new communities like we probably should, meaning a new group that we haven't touched before. And that's where some of the folks hopefully on this committee can help us kind of get into places where we haven't been able to get in before, where we're not currently providing a program or a service, but we know that that's a voice that needs to be heard, right? So, for example, we're doing a lot within the Louisville urban metro area. We're also doing in Lexington, we're doing Eastern Kentucky in our rural areas, but we're not hearing much from the Western Kentucky, from the western part of the state. I think that's a definite gap where we're not getting enough input from those folks on that end of the state. And then we can do better just within our central and northern Kentucky area too. So I hope that answers your question a little bit.
Yeah, I was wondering. Thank you.
Yep.
What do you need from Western Kentucky? How can we facilitate that communication? Because I echo the concerns that have been expressed in regards to transportation. Transportation is a barrier that limits access to treatment and to prevention care. Also, the language and cultural competence. We focus a lot on creating a language competency, and I think that we don't do enough in regards to cultural competency, and those are two distinct competencies that needs to be developed in our systems of care. So my question to you is, how can I facilitate from our region in any way, shape, or form that communication?
So great question. One of the things that I think we really want to be a little more sensitive and being aware of is the need for those bridge builders, those connectors, those CHWs in Western Kentucky. I think we've done a great job with Home Place and making sure that they're in the eastern part of the state, but we really don't have as much coverage for CHWs in the western part of the state and how they could be great connectors. And as far as the language and competency piece, what does that look like for you when you say competency from the provider side and the systems of care side, or competencies that the communities would like to see. So which one, Dr. Figueroa?
I think it's both. I know
Okay.
people that, for example, wanted to become interpreters, and there was a lack of training to become court-appointed or certified interpreters, and that's a missed opportunity. And that's something that we could help develop a public campaign, and in our social networks. We have advisory councils for our services, and clients and community leaders participate. And we have a person that work with communities, Latino communities across the state. And so he has the pulse over that community. It's a great opportunity for us to expand in that particular area. We have a growing Burmese community, and they lack services. Also, we recently opened the doors to the Afghan refugees, and the cultural competency and linguistic competency was a challenge and continues to be. And so those are some of the things that I would like to see, that that perhaps we can work together or influence other systems in the state that could offer and build that capacity in that particular area. Nothing can substitute the value of sitting and together and inviting the community to express their concerns and how they can be how can they have a greater voice, a stronger voice in the development of services. Service mapping, for example, will be essential, with an emphasis in getting cultural competency. And it could be, it's not just ethnicity, but sometimes we're talking about age groups, talking about different areas that we need to address, and communities that are marginalized. So I think that for one, as a CEO, I believe that our organization needs to do more, but at the same time, even though that we have strategized and we have expanded our search for bilingual employees, and increase the number and the opportunities for cultural competency training. I think that's something that we have to do across the systems.
So definitely, I hear you saying you already have some advocates and boots on the ground that can help with these conversations. When we really want to find out more about, definitely we're a population we're missing the mark on, and I say being totally transparent, is our refugee population, the Burmese and our African refugee population. We're just not able to get in and have those conversations that we need to have to find out we can best support them. And definitely doing more with our cultural competencies. I hate that word, Dr. Figueroa. I'm going to be honest. I don't like that word competency, because I don't believe you ever are culturally competent. I think that's
Right. Yes.
But I know that's
prefer?
the term that the medical community still uses, and having worn that hat. I know that's something that providers look for, but we're trying to put a health equity lens to the current class standards and cultural competencies that are out there on the OMH webpage. So we're looking for states to kind of pilot some of the things that we're doing, but stay tuned for that, because I think people are wanting to change some of those a bit, to have more of a health equity focus, and take a deeper dive into what those really look like. But I agree with what you're saying. I think we do need to have more interpreters, and what we can do to help facilitate that at the state level. If there's anything we can do based out of this group, I think that would be great as well. So I appreciate your comments.
Yeah, since we're having this conversation, I think language matters, and I understand what you're saying. At the same time, it's like, what would be an appropriate way of calling things? And I have to say, I like using the word competency for this reason, because as professionals, we don't want to be perceived as incompetent or that we're missing something, right? and it's easier, and it takes the message across that you are not competent when you have not developed those skills. Okay, and so it put back the responsibility on those individuals that are providing services in order to develop the skills, the talent, and also to work in advocacy areas. So I know that this is a work in progress, and as I say, language matters. But I just want to give you a little bit of perspective of how I could use it in that matter.
Appreciate it. Anyone else have comments? I've got a lot of different things down here: access, transportation, communication, language, and cultural competency, and then working with specific populations. We haven't talked about our seniors. If we feel like we're doing enough with that demographic, are we doing enough with some of our other groups? I mean, we can slice and dice it a number of ways, but I do think our seniors are sometimes forgotten. And we do have a aging population, longer than the previous 10 years or 20 years prior. We're living longer. So
Who works with seniors? Keisha, do you work with seniors? No. Anybody else? Keisha, do you have any specific senior?
Yes, I do work with seniors. I'm a social worker, but I don't deal with the financial piece of it as far as the Medicaid and Medicare and whatnot.
For behavioral health in particular, one of the biggest problems that we have in providing services to the seniors is that federal regulations, Medicare regulations, that allows only like psychologists and licensed social workers to provide services and get reimbursement for that. I know that currently there is a Congress passed legislation that would allow licensed professional counselors to provide services. So what's happening is that even though that we have therapists and we have other people that have license, Medicaid accept them as providers, but Medicare do not. And that really compromise access to services. And so that's one area that it seems that there was a solution, but it's a partial solution because they don't get paid at the same level, even though that they have the same kind of training. This was a matter of basically trade organizations that got to the table first and kind of control who can provide services or not. Has nothing to do with quality. But that's an area that I think that when we're looking at providing services for seniors, we have to take a look at, from a provider point of view, what are some of the barriers that we have in providing services to seniors. And so if something is not allowable at the state level, perhaps that's something at the federal level that perhaps we should take a look at those regulations and do something at the state level to build equity.
Noted. I just want to throw, the other demographic that we get dinged on a lot is our LGBTQ plus population, and are their voices being heard? And then, any other demographic that we feel like we should really be tapping into. I don't want to monopolize the time, Julia. I want to give Danita Coulter a chance to say something because she's with the health equity branch within the cabinet, within Medicaid. So Danita, if you have anything you want to add, I don't want to hog the whole conversation because we're in this together. So if you have any thoughts or ideas, please share. I know I'm putting you on the spot, maybe.
I think actually the group has not been introduced to me yet, and sort of they don't know my role. So I think we were kind of going out of order. So I guess we can use this time to introduce myself to the group. And if Angie wants to jump in first so she can sort of talk about how the group was restructured. I think I don't know, Dr. Richardson, we may be
I
going a
don't know
little
if we're
bit
at
out of
that point
order
yet.
on
I
your
don't know.
agenda.
Yeah, I don't want to supersede to Julia with the agenda, so. if
Yeah,
something
so
kind of turn,
I will
Julia,
defer at this time.
Well, great. I'm just loving the discussion. This is all under committee goals and strategies anyway, so it all will fit, but we can hold if you want to, Danita, till later in the agenda.
I just
go
want to
ahead.
add one other thing, Dr. Richardson, before we move on, is that when you say what equity issues are trending, of course, racial equity is always the topic now, having the harder conversation around the upstream root causes, but things that we're still hearing is that we're still in a pandemic. We still have a lot of misinformation and myths and things going out around COVID vaccine. And our numbers still need, in certain populations, still need to increase as far as vaccine uptake and increasing vaccine confidence. So I still don't want us to forget that we're still hearing that from community. So I just want us to keep that in the forefront too. And not just COVID, but immunizations in general. We're in a flu season that's just blown up and people aren't getting their flu vaccine either. So those are some, I think, pressing issues that we still need to kind of remember as we have conversations. So I'll defer back to you now, Julia.
Great. Well, thank you for leading that. I just had a couple of things to add. And this I think all falls under our committees and goals and strategies review. So just to go back to what Jordan said, even in the middle of Louisville, even though I'm in the South End, transportation still probably our #1 issue around achieving health goals from our perspective, not their goals at home, but as far as accessing healthcare and services, huge. I think we all know that federation is not an effective way to provide transportation to Medicaid recipients. We have known that for decades, I think. And to me, it's sort of like an elephant in the room, because we all know you call them, they don't show up, they go to the wrong house, you have to have all this notice. And it's certainly, I don't even know that it would take somebody 2 hours, Jordan. I can't remember when I was in Jackson County, if I could even get Federation to take somebody that far. So I think we don't even have to have a listening group to know that's going to be the biggest thing people talk about. And I know when we work with families, especially families that are that everybody wants to know what's the problems, right? Talking to refugee families, talking to families that are on Medicaid. They've told us for years what's wrong. So it's hard to go back to them and say, so tell us what's going on, when we know what's going on and haven't responded effectively to what they've told us. So I think that as we're asking Medicaid recipients what they see the challenges are, I think we have to go in and say, we know what you've been telling us and know we've not been able to fix it yet, but we still want to know, how do you have that conversation with somebody that's already been telling you what's wrong? So I think that's a challenge with listening. So anyway, transportation, huge issue, even in Louisville. I think that if as a group, if that's the one thing that you get from the TAC, is transportation is a huge issue. And we're happy to try to help get you more information if you need that, or help figure out what the issues are, but huge. Okay. Access to care. I know you talked, Vivian, about vaccines. Access to vaccines is a huge issue. Access to vaccines. And it's because there's nobody to give people the shot, right? We're in a nursing shortage. They can't just go to Walgreens, right? You have to get your appointment online. Even if, Medicaid covers the vaccine, there's barriers. You can't just walk into Walgreens, get a flu shot. You can't just walk into the health department. In Jefferson County, you wait very limited hours to get vaccines. So even though we hear about there's vaccine hesitancy, honestly, 10 people a day, I can't give a vaccine to because I don't have nursing staff and I can't send them anywhere. So we have to pay attention to that access issue. Subspecialty care. If you have Medicaid and you want to see a rheumatologist, it's like you have zero access. My husband private insurance, wanted to see my rheumatologist 1 week, right? So access to subspecialty care is extremely important because it is very different. Same with GI. If you have Medicaid in Louisville and you want to see GI, maybe in the summer. And if you have commercial insurance, it's next week. And so that's got to be a payment issue. You know, there's a lot of reasons why subspecialists don't want to take Medicaid, but that's something to definitely look at. Just to share our stories at Family Health Center, we were very limited in our cultural and linguistic maturity, for lack of a better word. Every person that came in that needed an interpreter, it was like, oh, what do we do? What do we do? You know, this is 15 years ago. We open the door to interpretive services. Hey, you know, of course, we have to pay it all ourselves. And that transformed our cultural competence, using the competency word. Because if you don't have language access, that creates bias isn't even the right word. But if you don't have a way to provide interpreter services easily, then that patient becomes a problem, right? To the front office, to nursing, to the doctor, that patient becomes a problem if you don't have language. And Medicaid in Kentucky doesn't pay for interpreters. So another elephant in the room, many states do. And so I think a really serious look at Medicaid paying for interpreters. And then you mentioned the CHWs. I think, like you said, I think Kentucky led the way, right? For decades with Kentucky Home Place. We told the story from the beginning. So I would hope that we have enough stories and enough data to show that in our state, it's crazy effective, and that we just need to, and it's cheap, and it changes lives. And so I hope that we can continue those that progress that we've been inching along with. Because the other thing is, if you want SNAP in Louisville, 30 minutes minimum on the phone, 45 minutes sometimes. Maybe you get hung up on, maybe you don't. People can't access SNAP. They can't access WIC hardly. And so these, that's why we need community health workers, right? To help, because our systems are so hard to navigate. And it was different when I was in Jackson County. I could access those services really easily. There was, you know, it was just smaller scale, maybe, I don't know. But so again, you know, community health workers is a Band-Aid, right? Because our systems are too complicated. We had easier to navigate systems. We wouldn't need to figure out how we're going to pay for community health workers. So a lot of that's just reiterating what others have said, but I think that I just realized during this conversation how we didn't change as an organization until we aggressively paid for interpreters. And that led us to be able to approach the situation of somebody who you can't communicate with completely different. And now I think many families come to us, not to see me, but because we have interpreters, right? And then that made me a better doctor because I know I just have a lot more experience. So I think that could go a long way around paying for interpreters.
The other thing is differential pay for bilingual clinical staff, because that works, that helps to retain them and to even encourage some individuals to go into a particular field that we struggle to have professionals.
And that goes right to DMS workforce ideas.
Right.
That's a great point. All right, well, I hear a pause, so I'm going to move on to new business, and we are at 2:05. Okay, so there's some informational things on here as well, and then some more discussion things. So we'll start with the CCBHC. We had brought that up just a little bit at the last meeting, and people wanted more information. And so who's going to tell us about that?
That's going to be me. And I realize this is new business. We usually have new business and then we give you the information the next time. But I'm pretty familiar with CCBHC and some of the other items on here, so I thought we would go ahead and give you what we have. Let me see if I can share my screen. And this is a presentation that we gave, let's see, I think we gave it out to the SEAC, State Interagency Council, maybe a month or so ago. So I'll just go over this. So CCBHC stands for Kentucky's Certified Community Behavioral Health Clinics. I'm going to give you a little bit of background because sometimes it gets a little confusing. This is actually an initiative that started back in 2014 when our sister agency, the Department of Behavioral Health, applied. Congress enacted a program to test a model to improve behavioral as well as health, access, and integrated care. So it was any type of care that could be provided. It was kind of the first time that they're really trying to start talking about integrated healthcare and increasing access. In 2020, Medicaid received information that we were selected along with Michigan from this 2014 application. So it got a little confusing because we had to take the 2014 application and we were not allowed to change anything. So we had to use that 14 application. So I think for lack of reasoning, approximately 10 states were giving the award at that time. 1 or 2 did not stay in the demonstration. And so then later CMS said, hey, we've got some funds to go ahead and start maybe in 2 more states. So we started with Michigan. So we were selected, and our go live date, which there was a lot of prep because of 2014's information. CMS wasn't quite prepared in 2020 to get everything together and start working. So we did have a little bit of lag time for our go live, which was 2022 January. And then in 2022, also through the Safer Communities Act, Congress extended and decided to expand that demonstration through 2028. So we have it originally was 8 quarters, and now it is going to extend through 2028. What is CCBHC? They provide a comprehensive range, must provide a comprehensive range of mental health and substance use disorder services. CCBHCs are available to individuals in need of care. CCBHCs will provide regardless of the ability to pay or their place of residence. Some services that CCBHC can provide, and I'll just run through these quickly: crisis services, screening, assessment and diagnosis, treatment and planning, outpatient mental health and substance use services, primary care screening and monitoring, targeted case management, psychiatric rehabilitation, peer support and counselor services and family supports, intensive community-based mental health care for members of the armed forces and veterans, particularly those in rural areas. With this integrated care, this was a very much an initiative that CMS wanted us to ensure that we meet all the needs of all populations, such as making sure that we reach the elderly community, we reach the less fortunate, we reach the communities that are definitely in need, like the veterans groups and LGBTQ and all those different groups that we need to start addressing. So this was really our first integrated initiative for Kentucky. Our current CCBHC demonstration agencies, and I know this gets confusing again, based on the 2014 application, 4 of our community mental health centers, which are our CMHCs, not to be confused, were in the original application. So they in turn also ended up being 4 of our CCBHC. This is the only 4 we have through the demonstration period. So it's 7 county services, North Key, Navista, and Pathways. So at this time, we are not have not received guidance of when and how we can expand to other providers or other CMHCs or other providers in Kentucky. Oops, I'm sorry, I hit the wrong number. I think that's it. So Dana McKenna runs this program out of Medicaid under our Behavioral Health Initiatives group. And we partner every day with our sister agency, the Department of Behavioral Health, and Dr. Robbins has been very much a part of that. I don't know if she's on, but she's a very much a part of this group, and we meet on a regular basis every week. So is there any questions about CCBHC or any follow-up that you would want from that?
Thank you. And what age, like, are you going down to like 2 and 3 year olds, or is this adult focused?
I don't believe there was an age limit on this group. I think it was for anybody in need.
As it's being operationalized, do you know if they're hitting the full age range?
So we just started in January of 2022. So we're just now, CMS is going to require quite a few like quality measures. And so we've been working through that with our community mental health centers. And so I might be able to provide more information on that later if you would like.
I think it would be helpful. We know that as far as looking at equity issues, behavioral health is such an important piece of the puzzle, and looking at, it'd be interesting to see what kind of data they're looking at. Are they breaking it down with race and ethnicity, age? So maybe, yeah, just a
I can see what we have. I think we've talked about this before. Our current system is not wonderful related to the data. I can give you some data. What we end up a lot of times are submissions that say other. And so that's not going to give you a whole lot of data. Like for behavioral health, I think we looked at that in the past, and I think we had like 80% participation, but then 50% I think was not either not accurate or listed as other, or blank. So some of the fields were blank. So this is a great initiative. We're very excited about it. We're looking forward to coming out of demonstration and hopefully add this to the state plan if permitted to do so. And so that very, very good group to work with.
Any questions on the CCBHCs?
I have to say that at River Valley, we're looking forward to be part of that group later on. We were not part of the original. However, 3 years ago, we applied for a CCBHC grant directly to the federal, to SAMHSA, and we were granted that. And we established the CCBHC in 7 counties. And it has been a game changer because it really removed, it allows people to access services, especially services that otherwise they will not have access to. 24/7 mental health mobile crisis, MAT services, the integration of physical health and behavioral health is such a wonderful way of this. It's refreshing to see that system in place. So we look forward to be part of that, and I think that the Department of Behavioral Health is doing a fantastic job in securing that designation for the Commonwealth.
Thank you, Wanda. The minority health or status health report, Vivian gave us the link to that, and it's in the chat if you didn't see it. I don't know if you wanted to give us a high level, anything you want to, anything. Oh, look, Vivian's gone. Anything anybody else speak to the minority status health report or health status report? Sorry. Well, we will review it. We've got the link and we'll keep it on for next time if people have questions or comments on that. Great. Okay. And then the Equity and Determinants of Health Branch Manager. Did I get that title right?
Yes. Hello, I am Angie Parker. I'm the Director of Quality and Population Health. And as Vivian had mentioned earlier, we do have a branch manager for our Equity and Determinants of Health branch, which is Danita Coulter. And she actually started on November 2nd, the day of the last meeting. So she's been here a little over 2 months. And we, within the Division of Quality and Population Health, this is a new division within Medicaid that was established in July of 2022. And so I have been working feverishly and getting this division set up, and with 4 branches, one being the equity and determinants of health, 1 quality, 1 population health, and 1 research and analytics. So I will, and all of these things kind of fit together, as you would imagine, but we are, because this is a disparity and TAC, I wanted to introduce to you Danita Coulter, to you, and who you all would probably be working with as you've discussed partnering and identifying areas in which you have noticed and where we could potentially focus, because we know we can't work within in a bubble, and everything that touches the health of our enrollees is equity, should be equity driven. So Danita.
I thank you for that, Angie. Again, so my name is Danita Coulter, and as Angie said, I came on board in November. I am familiar with working with the enrollees with Medicaid. I came to this department directly from University of Kentucky. I was working with what was called the Kentucky Injury Prevention and Research Center, working specifically towards injury prevention and prevention of injuries that would sort of guide policy that would control those injuries and sort of create policies that would prevent those injuries. Sort of the same thing that we're doing towards this equity work. So before that, I spent 10 years working for, I'm sure some of you are familiar with Community Action Council, where I work very closely with many of the enrollees with the Kentucky Medicaid program. So some of these challenges that I've heard you mention today, like with the transportation, the language barrier, and all of those things. So I've witnessed those firsthand with those enrollees and work with them to try to accomplish ways to meet these challenges and barriers. So I'm happy to be in this position to work with like-minded people who are creating ways to address these barriers. The Medicaid Initiative Collaborative, we do have that kickoff scheduled on January the 12th, and that one question about working with the NCOs, we will be working closely with you all to get your feedback. Angie has scheduled a meeting with you all, working on providing some pretty detailed information on what we've been doing as a group and what we hope to do with you all in the future, you know, to collaborate and identify some other partners. So you have my name, you have my information. I look forward to working with you all and sort of picking up where Jody and Deputy Commissioner Hoffman left off with this great work. So thank you.
Thank you. Thanks for your introduction. Nice to meet you. Is there, since we have some time at the meeting today, is there anything that we could offer, Danita, for you to help you in your work thus far? Any questions for us or feedback that we could give you? Oh, you're on mute.
The information that I've been hearing and the feedback that I've been hearing from this group, I've been taking notes, and of course, the minutes are available, and our team meets pretty regularly so that we can, you know, find ways to act on what we've heard from these groups. So right now, I think that I'm fine, but we will let you know if there's anything that we need further, but thank you for asking.
Let me ask you, if we took to the MAC, for example, you know, a comprehensive evaluation of federation and what's working and what's not working, for example, would that be helpful? Is that a role that the TAC could play that would help to get the transportation issue not prioritize, that's not the right word, but brainstorming to try to find some solutions? Or is there a role like that we could play?
I think,
Go ahead.
go ahead, Angie.
Well, I mean, I don't know that that's a recommendation you would need to make to the MAC at this point. With the discussion we're having today, and we, you know, as DMS, we do recognize that transportation has been a huge problem, and how we address that is it's something that we can also target or focus on our end. You know, access to care in general. For you mentioned that a commercial insurer can get in quicker than a Medicaid. You know, that's we're aware of that. So how do we fix that? And it comes down to providers, and you know, there's a lot of pieces and parts and puzzle pieces that we all have to determine what we can fit together and where we need to focus. But I think at this point, we will, you know, things that I got on my list was, as Deanita probably has the same, as transportation, telehealth, how to utilize that. And we know there are gaps in that. The access to subspecialty care, access to vaccinations, and interpreter services. So which is on the next, which is 5D, is quality strategy for Medicaid and review of equity focus. All of these things are a focus. It's how much we contribute as far as our time and efforts and energy, because there are so many things and so many people. Where are people working on certain things? Who is working on certain things? Is there somewhere out there people are already working on transportation? We are. I can tell you that we already are. We haven't got an easy fix yet, but we do appreciate the feedback from this. And I can tell you one of our biggest challenges in identifying is data of those persons of race and ethnicity, and trying to drill down on, because as Deputy Commissioner Hoffman mentioned earlier, people either don't check the box or they say other. So it helps us. It does not help that we aren't able to identify those areas for racial equity because we don't know. So how do we fix that? How do people feel comfortable of even checking that box? Because data helps drive a lot of what we do and what we intend to do. And anything that you all as a group can help us identifying, or the people that you serve, identifying their race and ethnicity, will also help in the data and to determine, okay, where are our biggest barriers to care and for what groups. We can all anecdotally come up with information or, what we think is the issue, but data really does drive a lot of what we need to be utilizing to also focus.
Great. Thank you for that. And also thinking about, like you said, a lot of the feedback and discussion we've had today is fantastic. It's not news to you all. And so how can we provide information that is different in some way, or more, I guess, looking at the role of this TAC, how you feel like, just ideas moving forward, how you feel our voice is most helpful. Because again, you all know these things, and you don't need us to tell you again, but what could we tell you in what way? So, and I don't know the answer to that, but any ideas you all have on how we can most effectively use our voice for you all would be great.
Well, yes, and we know these, but we also need to hear it from you all too. I think it's very
Okay.
helpful. And that's why we have this TAC.
Good, good. Well, we want to be
You know,
helpful. but
how we can work together to resolve some of these issues and some ideas you may have, as you said, to help with transportation. You know, we're a collaborative group here and we all have different ideas and or outside, like I like to think outside the box type things. So yes, we appreciate this, and that's why, you know, the conversation today does help strengthen what we already know, but it's at this point, so it's what are we going to do about it?
Let me ask you a question on the data. So for example, I know Jordan and I, where we are at are you at FQHC or Rural Health Clinic, Jordan?
It's a RUC.
Yeah. So at FQHCs and RHCs, we have that data, right? So we collected race and ethnicity data. So and probably Wanda, you probably have it on yours. So there are those of us, we have the data. So pilots on looking at data could be, because we have it in matching lists, something like that could be an innovative way. Second thing I wanted to bring up is NCQA, I believe, is starting to require that data. And what is that going to force CMS then to make it a force field, or what do you know about that?
Well, that's a good question, because NCQA, yes, they are, you know, opening up their accreditations and measures regarding health and racial equity. And all of our 6 MCOs are NCQA accredited. So this is something that, you know, that they would also have to make sure that they are focusing on as well. And with our quality strategy, everything we do actually within the department is focused, or equity is a part of that. Through our RFPs, through our procurement, through our MCO contracts, you know, I believe the Deputy Commissioner mentioned this in a previous meeting, that everything we do has an equity portion to, or focus to, what we are doing, and ensuring that that is on the forefront. But how CMS will take this, it's hard to say, because as you said, we can't make people fill check the box, and because it is something that they can just move on past. But I wasn't aware that your FQHCs and RHCs are able to track this information. So yes, I think that would be a very great idea to kind of see some of your data and what you're seeing as well.
And then the other thing, you know, when I've you know, in quality improvement world, you know, you kind of deal with the data you have a lot of time. And is there a way to, you know, deal with the data we have and try to make some observations? You know, it's not a research project, but make some quality improvement observations that could inform some of the work that I think people are holding off on because the data is not good. But there is some data, you know, like you said, I think, is it 50% you have? I know some of the MCOs have said maybe they have 50% race and ethnicity data. And that's better than nothing.
Yes.
I don't know from y'all, from DMS's perspective, do you feel like you can move forward making some observations or you know, using the data that you already have?
Yes, we're looking, I mean, we are looking at that, and we're, you know, we do request, we have a COVID report that each MCO does, and it's broken down by race and ethnicity if they're able to obtain that. And I know that each MCO is also working to get that information in different avenues, whether or not if it's a member who calls in, if it's a question they can ask, you know, for other reasons. But so yes, I mean, they all are working toward and assisting with obtaining that information, but there's no easy fix. So
right, yeah. I just feel like a lot of times it's a barrier to moving forward because people feel like, well, we don't have enough data, so we can't look at
No, I
disparity
think,
data.
I think we have enough data. Let's put it that way. I mean, you have to, I'm not a statistician, but you have to evaluate the amount that you have, and, there's ways around that to figure out the percentage of this, that, and the other. But yes, I think we have some data that we can come with some conclusions, or at least hypothesize about. Like I said, a lot of things we talk about is anecdotal, but that anecdotal usually turns into definitive.
Mhm.
Um,
And
just,
I
it's
know
just
this
that we just
group,
don't have the numbers specifically.
right. And I know this group definitely wants to be involved in looking at that data. So I don't know if there's anything that you have for the next meeting or could bring.
There might be, I can look at that, but what Danita just talked about, we're meeting with the MCOs. They each have, what are they doing regarding equity, and kind of getting a general idea, and working with the Medicaid Innovation Collaborative as well. But I might be able to have some data for you by then. I would like to, but I'll know more after January 13th.
Great. And then in the really important points in the chat, Miranda said that, they're arbitrary boxes, right? So people have a hard time checking the boxes when they don't feel the race and ethnicity labels describe them. DMS convened a work group last summer focused on immigrants, wherein we discussed changing the wording of the race and ethnicity question and responses. Do you know about that work group, Angie? That would be good to get some feedback from that. I don't know, Miranda, can you share who you worked with?
Hi, yes, I think the Commissioner Miranda Straub convened it, and maybe Lisa Lee was also involved, but it was a work group specifically focused on how immigrants experience the Medicaid application and ways to make it better. And so that was one of the issues we discussed, was how that question is asked and the response options. And we looked at, information from the census and how they have studied how to ask that question effectively. And we pulled some of their data and testing on how to ask about race and ethnicity. And I'm not sure what flexibility the state has to reword that, but it is something that we explored and using evidence that has been collected and studied. So I would still really be interested in seeing that changed.
Yeah, I knew that it was being considered and or worked on, but I think Miranda, you bring up a good point. What we can change, what CMS will allow us to change is the question. So, yes.
That's great, Miranda. I don't know if we could get, I'm sorry, yeah, Miranda. Who did you say you worked with? Or who led that?
Commissioner Marta Miranda Straub had been involved in convening those meetings.
But she's now retired. So Lisa Dennis is now the commissioner over DCBS. So she may have some information on that.
Sounds like it was a really good conversation with the community. I bet there was a lot of good information. I don't know if there's any way to access that. I don't know, Angie, if you could talk to Marta's the new person.
I'll see what I can find out.
Okay. Thank you. And then the quality strategy for Medicaid, we talked about that last time. And then just to help us understand as a group, as a TAC, what areas that you're just telling us what you're focusing on in the quality strategy that we might need to know about.
Well, you need to know about all of it, actually. I mean, but this is a dynamic document, and we do have a specific page or area for it's called Health Disparity Initiatives. So we do have, part of this strategy are initiatives in addressing health disparity, equity, social determinants of health. But it's all of all the measures that we look at, as I mentioned earlier, equity has a piece of everything that we do. So I believe Aaron did forward the quality strategy to you all after the last meeting. So, I know it's not your favorite thing to take time to read, but there are certain, I would think just look at some of the areas and, the goals and measures that we're looking at. And, if you read a good book, you read the first part and then the middle and then the end, you might be able to figure it might be helpful. If you don't want to read the Cliff Note version of it, but
Great, and we'll resend that after the meeting and put it on the TAC website, so we have easy reference. So when we want to look at it, it'll be there. Great. The next thing we asked for an update on, so we talked about the CHFS listens, the I guess it's a phone, it's just phone, right? It's not email, or is it both? I can't remember who talked to us about it last time. So they said that they get phone calls and people connecting, and we were wondering, based on what they're hearing right now, if there are any equity issues to share with us.
Aaron, do you want to speak to that? I'm sorry.
Yes, I actually receive all of the CHFS Listen emails that go for Medicaid issues. I can reach out to the ombudsman, excuse me, pardon me, the ombudsman's office and see if they keep and run and track any reports. It is an email. We do sometimes get voicemails sent from them, but they're not as frequent as the emails. I can tell you just from my personal experience of dealing with those on a daily basis, I don't see any equity trends or issues that seem to be consistent. A lot of the times it's providers who can't log into the system, members looking to make sure they're active, or access to, looking for a dentist in their area. A lot of time we've got to check, we're not sure which patient this goes for. It's a lot of those types of things, but I will reach out to the ombudsman's office to see if they have a report that they can run to see if there's any trends that they see that don't necessarily always come across my desk, but they do send me 100% of the Medicaid issues, and I filter those out to staff, have them address, and we filter those back through the ombudsman's office. But a lot of the times it's providers reaching out, they've locked themselves out of the system, they're having issues with an MCO, recertification issues, those type of things. But I will reach out to the ombudsman's office, and if you want to put that on your old business in the next agenda, I'll see if there's any kind of report or feedback that I can get from the ombudsman's office.
So the CHFS listens, Aaron, I'm just making sure, I haven't seen any related to equity. So for health, racial and health equity. So I'm guessing each department, like Medicaid, is divvied out those that they receive, right, from the ombudsman. So
that would be my guess.
We wouldn't have all of them. We would just have the Department of Medicaids within the cabinet.
Yes, ma'am, that is correct. That's why I'll reach out to them and see if they track those in any way that they can run a report and can follow up for the next meeting. I may or may not be on the next meeting, just depending on when baby decides he wants to come. So I will make sure that Kelly has that information.
And maybe, Aaron, I'm thinking maybe the patients that had significant complaints about LGBTQ issues, those probably came from that line. Is that correct?
Yes, ma'am. I believe I've sent you 2 of those issues.
Yeah. Okay.
I wouldn't necessarily say that's trending. It's not something I see frequently, but I'll reach out to them.
Thanks.
Great, thanks, Aaron. Yeah, and even trending might be too strong of a word. Just what health equity issues are you hearing? Maybe is a better better term there, just so we can have a chance to reflect on those and provide feedback as a TAC. Great. Okay. Immunization. This was one real specific thing that I brought up before around equity is immunization fee schedule update. So just to recap, many pediatric providers that provide care with Medicaid families are participate in the Vaccines for Children program, but many do not, and they do not vaccinate those kids. They send them someplace else for the vaccines, or might do their well check or see them for a sick visit, and then send them elsewhere because they say that the fee schedule isn't in line with their costs. So they have purchased vaccine in the refrigerator that they give to commercially insured kids, but not to Medicaid insured kids. And in the past, Lisa Lee, this was a top priority. Well, not Lisa, but oh shoot, another woman in Medicaid, it was a priority, and she several years ago updated the fee schedule really effectively, but then time has passed and the fee schedule is again out of date. And we wanted to try to get those in line so that a child under Medicaid doesn't have to leave and try to start knocking on doors and try to get their vaccines. And I think, Judy, I know you had started to look into it. I didn't know if there were any updates or next steps on that.
Erica, are you on the call?
Yes, I'm on. I wanted to ask Dr. Richardson, is it a question of increasing the rate for the administration of the vaccine or the cost of the vaccine?
So the first issue is the cost of the vaccine. And I think the administration rate is an issue, but I think first and foremost, it's the medication fee. So I recently, earlier this year, I saw a child for a vaccine only, or maybe I saw him for a sick visit, I can't remember. And I said, oh, and they said, well, we're gonna have to come back here for vaccines because our pediatrician won't give them to us because, you know, they say, you know, I can't get them there. And so I thought, we're gonna fix this. And I called the pediatrician's office and I said, oh, no, the fee schedule, it's all updated. I promise you that you're gonna get paid. And the office manager pulled it up and she said, we cannot give vaccines if we're gonna lose this much money per vaccine. And I think there's also some historic information when the fee schedule was way off. So the pediatric offices didn't even look at it, but there for a period of years, it did really match what their costs were. And it's now outdated.
I think we brought this up with Justin, it was probably several months ago now, because right, the cost when you look at it look okay, but it's just out of date now.
It's not way off. It's just
it's not way off. Yeah,
just enough, you know, $10-20 here and there. But businesses like doctors' offices will not just take that hit of, you know, $100 here or there for a set of vaccines.
I'll take the issue back to Justin and see if there's any work that he's done specifically on it. And if it hasn't moved forward very much, then it'll be a priority of mine.
Thank you. And then I think once you all look and you think that it's where it needs to be, I think we need to vet it with some doctors' offices to make sure that the costs that you have researched are in reality what they're paying, you know, just to vet it before you put it into stone, so it doesn't have to be changed twice. The next thing on the agenda,
Dr. Cantor has her hand raised, sorry.
Oh, I'm sorry. Hey, Divya.
Yes, thank you. I wanted
I think you're cutting out.
to talk about the payment for the vaccinations. I was talking with Dr. Harry. Oh, am I cutting out? I'm gonna turn my camera off. I'm having bandwidth issues.
Okay. Yeah, you sound better with your camera off.
Here. So let me try that. I was talking with Dr. Harrington in Department of Epidemiology about specifically the patients, especially with the FQHCs, and we were noodling around how to be able to better inform the providers about payment, and just wanted to throw that out there that it's recognized to us that there's
Dr. Cantor, you're
um,
still
perhaps
cutting
some
out.
gap
If you could either send me an
on the
email,
best
send it to the TAC,
way
or drop it in the chat. We're only catching about every
to
other
get
fifth word.
reimbursed for this, given the RAP payment around all of the vaccinations. I do recognize that fee schedule needs to be updated, that perhaps some better practices around how to be able to code and get the full. Oh, I'll put it in the chat. I'm so sorry. Oh
Sorry.
gosh, darn.
Yeah, we're only hearing every third word. And that may be a different topic. This is for non-FQ oral health clinic people, non-VFC providers rather. This is an issue for non-VFC providers, and we're all VFC providers. So I think this might be another topic, but I couldn't really hear, so I'm not sure. Okay, great. And then the next thing on the agenda is community health workers. People had wanted to hear what's going on with the DPH funded program and possibility of expansion and how that's going to be paid. I don't know if there's anybody on the call still that can talk about that. Anybody?
This is Angie with Medicaid. I can't talk to the DPH funded program. I can talk to adding community health workers within Medicaid.
Okay. Please.
That's basically it. No, we have submitted a request to update the state plan amendment a few weeks ago to pay for community health workers, and there's certain criteria around that. So we're still waiting on CMS about that. Obviously, if a community health worker is part of the DPH funded program, we would not be reimbursing as well.
Right.
But it is, if a provider such as yourself hired a community health worker, they could bill for 2 particular codes, and it would be paid if the state plan amendment is approved.
Oh, interesting. So, is that SPA available for public review, or is it private?
No, ma'am, it's not at this time. It's over to CMS for an informal review.
Okay.
And then once that we get their feedback, we'll be submitting that for their formal review. We like to have things informally reviewed, so that way it makes it a lot easier to get it approved within their 90-day time frame. But that is not typically something that is shared with until it's approved by CMS.
Great. Okay. Oh, good. Well, we're excited to hear what happens.
Mm-hmm.
Okay. So we are at 10 minutes. We have 10 minutes left, and I think a lot of our general discussion fell under our committee goals and strategies. So that's fantastic. But we do have a general discussion placeholder always on the agenda. This is a time if there's a new issue that you want to talk about in the future or bring up now for conversation, we have time to do that. Any topics?
Fairly infrequent occurrence, but it does come up at times. and this may or may not be fully true, but I've encountered a couple times, like I'll have infants that come in, like they're supposed to come in for a 2-month well check, but they come in at like 7 weeks old. So they're not quite at that 2-month threshold, but they're old enough to get their vaccines. So after 6 weeks, you can technically get their vaccines. And so they'll be like 7.5, like 8 weeks, but not quite 2 months old. And I could do the vaccines, but I was told that technically, like, even though per guidelines, they could get the vaccines at that point, they like Medicaid wouldn't cover the vaccines at that date. And so, I mean, I could do them, but like, you know, that's like basically like the same thing, right? The clinic's not actually going to get paid if we do the vaccines like today versus 3 days from now. And so for family convenience, like I'll do them, but like again, it falls back to the transport. Like I can't have that family come back next week. I can't ask them, and it's unnecessary. Like medically, I could get the vaccines today, but like from a payment standpoint, it's unfortunate that like that is a knock either against us for doing it, like even though I'm following guidelines, versus you know, the family if I ask them to come back next week. It just feels like kind of unnecessary.
Can you send in examples of that? So
yeah.
I think Judy needs rejected payments. Is that what you need?
Yes. Because I think, I mean, we give shots early all the time. At least I used to when I saw patients, and we were reimbursed. So
yeah. And I'll check in on it. I mean, that's just, I've went to do it before, and I have done it before, but was told that if we did it, like we wouldn't. So I'll actually check in on what actually happened once it was done to see if there was any issue with actually getting reimbursed or not. But I've definitely been told it a couple times.
Okay. Plus, I think for being in a, are you talking about VFC immunizations or?
Yeah.
Okay.
I think that's a really important point, Jordan, because I think there's a lot of beliefs around those payment windows for EPSTT visits. So if the 2-year-old comes in at 2 years and 4 months, or if they come in at 1 year and, you know, 11 months, like what's the window that's paid? I think there's a lot of historical, not misinformation, but confusion. And that would be a great thing. And I don't know, Judy, if we can get that information from Medicaid without getting rejections, like for a statement from Medicaid that says, if you're close enough, we're going to pay. Or so, you know, I know you're not going to say that, but we used to have really strict windows when we were sole source passport. There were very particular windows, but I've been under the impression that those windows don't exist under anymore.
Yes, I don't think they do. I can look into that. I do. The biggest problem I had is if you were, you know, 4 days early for your 4-year-old shots.
Right.
And it was the school system that you know, they were the ones that were saying, no, this isn't appropriate, and demanding that the child be re-immunized. And, you know, so it wasn't Medicaid or anybody, it was in this case, Jefferson County Public Schools. And so we, in that case, we had to write letters and, you know, do all that stuff to make sure the kid didn't have to be re-immunized.
And those ones are legitimate as far as like, you know, you don't do like MMRV before 4, you don't do the Kinrex before 4, you don't give your first MMR and your hepatitis A before 12 months. Like, you know, that's following like CDC recommendation, things like that, unless there's special circumstances, obviously. But like the one where, you know, you do follow, like it's at 6 weeks, but like that was like, those were the ones that more I'm like, why? And again, I'll check to try to confirm that was an issue, whether for or against, but I was definitely somewhere along the line, it was a problem at some point. And I'll check to make sure it either isn't or isn't resolved.
Because I also do a lot at 6 weeks. You know, they're there, do it, and they're okay.
But it's not just your practice, Jordan. I think practices across the state do have those same, they'll reschedule patients because they're a day too early for their 9-month checkup. And there aren't any shots at 9 months, like you just do the checkup. So that would be a great clarification point. Thanks. Any other general discussion ideas? All right, and then it doesn't seem like we came up with any set recommendations to submit to the MAC, unless I'm forgetting. Looks like we didn't. And then Dr. Batista has graciously volunteered to try when she can to attend the MAC meetings, and the next one's January the 26th at 10. And then you can give us an idea of what some of the other discussions were that were health equity or could have been more focused on health equity, and then gives us some ideas to what they're talking about. We meet again March 1st at 1 p.m. Any other business? I'm just going to read what Dr. Cantor said. She said she's sorry about our audio. I believe there's an opportunity for improved education about payments for vaccines as it relates to FQHC. So we'll follow up with her to collaborate on that specifically around FQHCs. We are at time. Is there a motion to adjourn?
I motion to adjourn.
Is there a second?
I second.
All those in favor say aye.
Aye.
Motion passed by acclamation. So thanks for everyone's time, and we'll meet again in March. And then whoever wants to be chair next, I'll do it one more time, and then I shall resign as chair and somebody else can do it.
Thank you.
Thanks.
Thank you.